Imagine taking a medication designed to stop seizures only to discover it might help save a diabetic foot. What medication you think I'm talking about? You thinking that I'm going to talk about gabapentin, right? No, nah. So today on Salvage Saturday is story of one of wound care's most unexpected heroes, and it's phenytoin. And I'm going to spell it out because sometimes I'm not the best with pronunciation. But phenytoin, it sounds like a fancy bag. Phenytoin, so phenytoin. And how did this neurological drug end up in wound care clinics and how it can really help diabetic foot ulcers heal faster, possibly? But it's always good to know all the different routes that we can take. So today's story isn't just about a wound care clinic or about a vascular lab or in the operating room. It begins with neurology. So imagine prescribing a medication to a patient that prevents seizures and then noticing something strange. The patient gums, the gums in their mouth start growing. Not cancer, not infection, not inflammation, but excessive tissue growth, like a lot of tissue growth. And for decades, clinicians considered this annoying side effect of the anti-seizure medication. And then somebody asked a brilliant question: what if this unwanted tissue growth could become a healing advantage? And thank you, whoever asked that question. You're fabulous. And thus began one of wound care's most fascinating journeys, the story of phenytoin. Phenytoin. So, what is phenytoin? Phenytoin was introduced in the 1930s as an anticonvulsant. So it's pretty early, still a baby of a drug, in my opinion, because it's so early, 1930s, but it revolutionized epilepsy treatment because it controlled seizures without causing this profound sedation associated with earlier drugs. And chemically, melatonin belongs to a class called hydantoins. And its primary neurological action involves stabilizing neuronal membranes, blocking voltage gated sodium channels, and preventing repetitive firing of neurons. And in simple terms, phenytoin calms the electrical storm in the brain, yet none of these neurological actions could explain why wounds might heal faster. And the answer came from an unexpected observation. So, one of the most famous principles in medicine is side effects reveal biology, right? And I think a lot of people know about the Viagra story, right? It was with, I think it was had to do with men with their hearts, and then they noticed that they had erections because of the nitric oxide increase, things like that. If I have the story wrong, forgive me, okay? But that's the story I was heard a little bit, but I'm pretty sure I might have it wrong. But that was a side effect, right? And they use the side effect now as like a main drug for it, right? But one of the most famous, like I said, is side effects reveal biology. And doctors noticed that the patients who were taking the phenytoin frequently develop something called gingival hyperplasia, which is the overgrowth of gum tissue, like the gum in your mouth. And sometimes it was symptomatic, sometimes it was severe because the gums became thick, fibrotic, highly vascular. And I'm like, light bulb goes there. And essentially creating excessive tissue. And researchers began asking, why is the tissue growing? What pathways are activated? Could these pathways help chronic wounds? Thank you, whoever asked that question as well. And this observation transformed phenytoin from a seizure medication into a wound healing candidate. So, as we all know, diabetic foot ulcers is not just simply a hole, it's a failed biological system. The healing becomes trapped and the wound exists in this chronic inflammatory state, right? And we already know our chronic diabetic foot ulcers are basically locked into this hostile biochemical state. And the core problems of the diabetic foot ulcer is hyperglycemia, which could lead to multiple problems and imbalances, but we have advanced glycation end products. There is an increase of reactive oxygen species, ROS. There's an increase in pro inflammatory cytokines like TNF alpha, L1, beta, and IL-6. There is increase in MMP2, MMP9, which is protease overload. There is a downregulation of tissue inhibitors of MMPs. There's a downregulation of VEGF, which is would cause or result in poor angiogenesis. and our fibroblasts are quieted, and the migration is impaired in a diabetic foot ulcer, and the macrophages get stuck in that M1 phase, which is the inflammatory mode. We want them in the M2 phase, okay? So, how does phenytoin change the wound environment? So, this is where things become fascinating. Phenytoin appears to attack multiple components of chronic pathology simultaneously. Phenytoin, it's not acting like a classic growth factor. Instead, it behaves like a microenvironment reprogrammer by affecting the cell membrane sodium channels in this indirect cellular activation effect. The calcium flux signaling. It actually affects the fibroblast gene expression, the cytokine modulation, as well as the protease balance, the balance between MMPs and TIMP axis, as well as the local vascular tone and endothelial behavior. So think of it less like growth juice and more like a reset switch on a dysfunctional wound biochemical network. So when it comes to the mechanisms of action of phenytoin, one big one is fibroblast activation. So as we know, in diabetic foot ulcers, our fibroblasts are very much impaired. They're quieted, like muted down. They're poorly responsive to growth factors. They're epigenically stuck. They are starved of oxygen, aka hypoxia, and they are suppressed by AGA, AGEs, and inflammation. And fibroblasts are among phenytoin's primary targets. And studies demonstrate there is an increase in fibroblast proliferation. Remember, I love me the proliferation phase of wound healing, right? And more fibroblasts, what does that mean? More collagen, more matrix, more tissue repair. So, what is the proposed mechanism of action of phenytoin helping with that? So, one is the sodium channel modulation, which causes an intracellular shift of calcium. So phenytoin stabilizes the voltage gate sodium channels in the neurons. But in fibroblasts, the membrane excitability changes slightly, and this affects the secondary calcium signaling pathway. And calcium is a master regulator of cell migration, proliferation, cytoskeletal remodeling, and the more intracellular calcium signaling there is, the more the fibroblasts are woken up. They're like you're shaking the fibroblasts, like wake up signal, right? Another hypothesized theory when it comes to helping with the fibroblasts, right? And in phenytoin is TGF beta pathway upregulation. So some studies suggest that phenytoin does increase the TGF beta 1 expression, and TGF beta 1 is a master fibroblast activator. So it will upregulate fibroblast proliferation, it will upregulate collagen gene transcription, and those genes are COL1A1 and COL3A1, and upregulate extracellular matrix synthesis. Another way it helps with the fibroblast proliferation is by epigenetic or aka transcriptional shifting. So chronic wounds are suppressed. They have their fibroblast genes suppressed, right? And phenytoin may reverse that suppression of the extracellular matrix related genes and improve the fibroblast responsiveness to certain growth factors like PDGF. Another mechanism of how phenytoin does help with wound healing or epithelialization is enhanced collagen synthesis. And collagen forms the structural backbone of healing, right? Collagen synthesis is mainly fibroblast driven as well. So this kind of piggybacks off of what we just mentioned. But the normal pathway is oral collagen production requires vitamin C dependent hydroxylation, oxygen, TGF beta signaling, and proline slash lysine incorporation. And in our diabetic foot ulcers, our reactive oxygen species damages the fibroblast mitochondria, the hypoxia reduces the hydroxylation, and the AGEs disrupt the collagen cross-linking. And so phenytoin affects this, like I said, the upregulation of the fibroblast gene, right? The COL-A1 and the COL3A transcription, and that results in more collagen type 1 and collagen type 3 synthesis, and it upregulates hydroxyproline content. So hydroxyproline equals it's a collagen stability marker, okay? And then, like I said, it improves extracellular matrix assembly. So better the fibroblast function, the more organized the extracellular matrix will be. So phenytoin promotes collagen deposition, matrix formation, as well as tissue stability. And the wound gains a stronger scaffold. And without collagen, healing cannot proceed. Another mechanism of action, now we're piggybacking off collagen, is that phenytoin is known to reduce collagen breakdown. So it helps build up collagen, but also reduce collagen breakdown. So remember MMPs? So research has suggested that phenytoin may reduce destructive collagenase activity. And this is quite huge because you're not merely building collagen, you're stopping the breakdown of collagen as well, right? Because remember, the people had that side effect of gingival hyperplasia. So they had an overgrowth of it. So phenytoin affects the downregulation of MMP2 and MMP9 activity. And the mechanism most likely is cytokine suppression, and that causes less MMP gene expression. It also upregulates the tissue inhibitors of the MMPs, and this would restore the balance. That's one of the biggest things that exists in diabetic foot ulcers. There's a huge imbalance. There are more MMPs than TIMPs in a diabetic foot ulcer. So there's more breakdown of the skin than upregulation of the skin, okay? And the apparently it's proposed that phenytoin restores that balance. So just think of MMPs, the matrix metalloproteinases, as scissors, and TIMPs, right? The tissue inhibitor metalloproteinases are like the brakes, okay? And phenytoin strengthens the brakes. Now, another thing is granulation tissue formation. That's what we want, right? Granulation nation, right? Thank you. So, granulation tissue is that red, beefy tissue clinicians as we love to see. So, we know that there's healing. So, there's capillaries, there's fibroblasts, there's inflammatory regulators, there are extracellular matrix, and phenytoin appears to accelerate us to get to granulation nation, granulation development. And that mechanism is the fibroblast proliferation is upregulated, so the scaffold formation is there. The angiogenesis signaling is upregulated, so there's capillary ingrowth. The extracellular matrix is stabilized via the collagen, so there's a stable structural matrix. And so clinically, we'll start seeing a red, beefy tissue, increased wound bed fill, and a faster transition to the epithelial phase. So this is one of the main reasons clinicians became interested in topical phenytoin. And then the angiogenesis. So as we know in our diabetic foot ulcers, the VEGF, so VEGF, I call it VEGF, signaling is impaired. Our nitric oxide is reduced, okay, and the epithelial cells are dysfunctional. And we know that's why we say vascular, 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 say it 3 times. Healing requires blood vessels, and phenytoin may stimulate endothelial activity, capillary growth, and microvascular formation. And this can improve our nutrient delivery. But they have proposed paths, but it was not really confirmed. They said that phenytoin does indirectly upregulate VEGF expression, likely secondary to the improved fibroblast signaling and reduced inflammation, causes endothelial cell stimulation through enhanced endothelial migration and improved capillary tube formation. And because there is better endothelial function, that is improved, results in improved microcirculation, which means more oxygen, which means more healing. Remember, oxygen is our currency. Now, another thing to remember importantly, that it does have some antibacterial effects, but phenytoin is not a true antimicrobial. It is not. So keep that in mind. And some studies have suggested that phenytoin exhibits some antibacterial properties, but and the way they say that is it's more indirectly. It's more like it changes the wound environment by changing the local pH. It alters the ionic balance. And it also has reduction of the exudate and improves the granulation, like I said, granulation nation. And then the mild inhibitory effects. So some studies have shown phenytoin has reduced growth of Staph aureus. When it comes to Pseudomonas is nothing to play around. Okay, I I had to battle with Pseudomonas with a few patients. Pseudomonas did not come to play. Okay, when you see Pseudomonas, That's a very tricky drug. I'm not saying drug, very tricky bacteria. They're very bold, out there, proud, and they're like, "I'm not going." Okay, so you gotta figure it out because that's a tricky one. Pseudomonas aeruginosa, yeah, like I said, I had one that was resistant to all oral antibiotics, and I was like, "Well, okay, let's figure this out." But we did. Thank you, Jesus, you know? But that was a very powerful resistant bacteria that we had to battle. So as we know, our chronic wounds are trapped in the inflammatory chaotic stage, right? So our DFUs, the macrophages stay in the M1 state. We want them to move to the M2 state, okay? But when they're in that M1 state, the macrophages, the TNF alpha is high, the IL-1 beta is high, the reactive oxygen species are high, and tissue destruction is ongoing. And phenytoin is supposed to downregulate the pro-inflammatory cytokines, so should downregulate the TNF alpha, the IL-1 beta, and the IL-6. Okay, so phenytoin may help regulate or modulate inflammatory signaling. They do hypothesize that it does help with macrophage polarization shifting it from M1 to M2. So when a macrophage is in M1, it's in the inflammatory stage. When a macrophage is in M2, it is in our repair stage. We want it to be in our repair stage, okay? We wanted to know when to move and give the the job to the other one, okay? So in a diabetic ulcer, the M1 macrophages, they're very greedy. They just want to stay there. They want to cause havoc. They're like the bad child, you know? Like he has a job. He does have a job, but he doesn't know when to leave. And we need the M2. So another thing that phenytoin is proposed to do is reduction of oxidative stress. So they propose that it helps indirectly as well. So it improves tissue oxygenation through angiogenesis as well as less inflammatory reactive oxygen species production. So this allows the transition towards proliferation, matrix deposition, as well as tissue repair, okay? Instead of being in that endless inflammatory stage. Now, most importantly, you have to remember, like I said, phenytoin does not act on just one pathway. It works like this. Step one, it downregulates inflammation by causing cytokine suppression. Step two, it downregulates MMP destruction. Okay. Step three, fibroblasts regain its responsiveness. It's woken up. Shake, shake. Step four, the collagen synthesis increases. Step five, we are at granulation nation. Granulation tissue forms. Step six, angiogenesis improves oxygen delivery. Step seven, healing shifts from stuck to progressive. So, when it comes to clinical applications of phenytoin, why does it work better in chronic wounds than acute wounds? Okay. You have to remember in acute wounds, they already have balanced MMPs and TMP ratio. They already have functional fibroblasts. They already have active angiogenesis. Phenytoin is most useful when the system is broken, not just because it's injured, but because it's in this chronic state, right? It needs a reset of reprogramming. And that's what happens a lot with our diabetic foot ulcers, okay? So things like chronic ulcers, non-healing ulcers, neuropathic ulcers are some of the indications for it. Some studies demonstrate that phenytoin does help accelerate some pressure injuries, but stasis ulcer, there is potential benefit in selected patients. Traumatic wounds, improved granulations may assist the healing. Like I said, granulation nation for our patients. Burned wounds, they have investigated it for epithelialization support. And when it comes to surgical wounds, they said that there is some potential application in delayed healing when it comes to that. But topical phenytoin is used. Historically, they have used it as a powder. So the capsules are opened directly onto the wound. Simple but inconsistent, okay? They have made some suspensions, which are prepared solutions that's more controlled. Some have used creams, which are compound formations. Some have had impregnated dressings, which are experimental delivery systems, potential future applications in the future. Now, when it comes to indications, like I said, potential candidates for this topical phenytoin are chronic diabetic foot ulcers, neuropathic ulcers, stalled wounds, slow granulating wounds, pressure injuries, venous ulcers, traumatic wounds. I mean, if anything, if it's not used so widely, do your research, right? Are clinical licensed practitioners. When it comes to contraindications, avoid use and caution if the patient has a known phenytoin allergy. That's an absolute contraindication. If the patient has malignant wounds, if they have malignant wounds, why would you put something that causes more overgrowth, right? We don't want that, right? So do not stimulate tissue growth without understanding the underlying pathology of what's ever going on. Another contraindication is untreated osteomyelitis. Infection must be addressed first. Phenytoin is not a substitute for infection control. If the patient has critical limb ischemia, no topical therapy can compensate for absent blood flow. So send them straight to vascular. Vascular intervention, vascularization remains priority no matter what. And when it comes to necrotic wounds, that's an absolute contraindication as well because debridement must occur. You cannot build on dead tissue, right? They say let the dead bury the dead, remove the dead tissue, okay? And like I said, scientifically, it has strongest evidence with fibroblast proliferation, collagen, upregulation of collagen deposition, and upregulation of granulation tissue, taking us to granulation nation. So, what are some of the common misconceptions about phenytoin? That phenytoin heals all wounds. In reality, it only helps certain wounds. That's what the wound care specialist is supposed to do to decide which wound care product is best for them. That's why I said I've noticed people do this one size fits all. It's absolutely not, but there is such a plethora of different tools that we use to heal different wounds. Every wound is different. Another myth is that it could replace debridement. Absolutely not. Okay, nothing replaces debridement. Debridement is the foundation of wound healing. Myth could replace offloading. Absolutely not. Yet again, without offloading, no diabetic foot ulcer can heal. Okay, so nothing can replace offloading. And like I said, it does not replace vascular intervention. Blood flow remains king. Okay, prioritization. And let's do some interesting facts about phenytoin. It's one of the wound care's greatest discoveries that came from a side effect, right? Gingival hyperplasia. Another fact is gingivitis hyperplasia occurs in up to half of the patients who use long-term phenytoin. And researchers have studied phenytoin for wound healing for over 50 years. And some clinicians call it one of wound care's original repurposed drugs. And the concept of drug repurposing is now become a major area when it comes to wound healing research. Okay. So researchers are now investigating phenytoin nanoparticles, hydrogel delivery systems, smart dressings, controlled release matrices, combination therapies, and bioengineered wound scaffolding. So the next generation of phenytoin therapy may look very different from sprinkling powder on a wound. So, Phenytoin reminds us of something very important. Sometimes the future of wound healing is not found in billion-dollar laboratories. Sometimes it's hidden in just a side effect. That's why you got to stop and listen and learn, right? A medication designed to quiet electrical storm in the brain unexpectedly revealed a pathway capable of stimulating tissue growth, collagen formation, angiogenesis, and granulation. And for our diabetic ulcers, a wound that's trapped in inflammation, protease access, fibroblast dysfunction, and vascular compromise, serotonin might offer some fascinating glimpse into how old drugs can find new purposes. Okay, and will it replace advanced therapies or biologics? Probably not. Okay. And it doesn't replace our foundations of offloading, vascular optimization, debridement, infection control, and metabolic management. Absolutely not, right? But in our limb salvage toolkit, phenytoin remains one of the most intriguing examples of how observation, curiosity, and science can help transform an unwanted side effect into a potential healing strategy. And in wound care, every strategy that helps us preserve tissue, prevent amputation, and restore function deserves our attention. And because everyone tells a story and every limb is worth saving, this is Diabetic Foot Files. I'm Dr. G, and take care of your feet because they take care of you.